It is very important to check the position of common equipment located within the patient on their chest X-ray. The endotracheal tube should be located in the midline within the trachea. It should be inserted far enough to ensure that it is not accidentally dislodged. If inserted too far, the tip of the tube will migrate into a main bronchus. In adults, this is usually the right because of its relative alignment with the trachea, whereas the left comes off at a more acute angle. In children, this anatomical difference is less significant, and either bronchus can be intubated. Ideal placement is usually related to an adjacent anatomical structure. For example, the tip should be level with the middle of the aortic knuckle. Remember that the patient's head position, particularly in children, and the position of the body will affect the location of the tip of the tube. The nasogastric tube should be visualized within the body of the stomach and not in the bronchus. Even when located in the distal esophagus, inadvertent feeding may increase the risk of aspiration. The ideal position of a central venous line is contentious. Case reports of pericardial tamponade following inadvertent atrial puncture have led to recommendations that the tip should sit within the SVC, above the reflection of the pericardium. The best marker of this on a chest X-ray is thought to be the level of the carina. However, it is also thought that the risk of perforation is related to the angle that the tip makes with the wall. Left-sided necklines may make a more acute angle with the wall of the atrium, increasing the risk of perforation, and some authorities have recommended the catheter tip sit lower, below the carina. Tip placement in the innominate vein is not recommended due to the theoretically higher risk of thrombosis and inaccurate measurements. While used less now than in the past, pulmonary artery catheters can occasionally be seen in clinical practice. The tip of the catheter may occasionally migrate distally, which increases the risk of pulmonary infarction or pulmonary artery rupture. Ideally, the tip should not sit more laterally than 3 cm from the midline of the chest. However, radiography rarely detects distal placement if clinical signs of this are absent, and many authors now do not recommend routine X-ray monitoring of position. The tip of the intra-aortic balloon pump is usually radio-opaque. It should sit just distally to the left subclavian artery origin, which is at the termination of the arch of the aorta. On a chest X-ray, this correlates with the second intercostal space on the left. The position of intercostal catheters should also be checked. The holes within the tube are clearly marked with a radio-opaque line and should sit within the chest cavity.